Welcome back to the Stepping In podcast. This is a special series where we're going to be looking back on the important stuff, the people in your workforce. Over the next couple episodes, we will revisit how systems undercut workforce. It never ceases to amaze me how frequently workforce issues are really leadership or lack of planning issues. Sit back and let's reflect on what we have learned to design a better system to promote and maximize efficiency. So let's bring the best to the front and let's focus on the people that we have, not the people we wished we had.
Well, here we are, another episode. What are we talking about today, Renee?
Yeah, we are continuing our series when we worked with children in hospitals, and we're going to be talking about hospital workplace violence prevention. When you work with kids, I don't know about you, Jason, but I used to get beat up working with kids in the psychiatric hospital back in the day, and I'm sure that trend is continuing. So we're going to talk about some statistics about what kind of workplace violence is going on, and then really talk about some solutions, what we can do about it, and how training can be a key factor in helping people not get injured at work. But before we do that, Jason, what is going on here in April on the farm?
Oh my goodness, it's April, so we're planting, and so when we think about planting season and all the work we did to fix everything and then just to fix it again as we break things. So, it's just the never-ending cycle, right? That's what farming's all about, is everything you think is perfect and then you're fixing it again and again
Yeah.
and again.
Well, I never got to ask, but did you ever get all the corn out of the bin?
No, I'm going to complain about that next episode.
Oh, okay.
No, we're planting and we still have corn to haul. So that's been a whole,
Well, I'm
3-month
figuring
ordeal
there's a
that shouldn't have
fix
been.
it component to that. Once that story concludes, there's
No,
probably more fixing it with the bin thing. So I'm guessing there's more to fix.
we're fully operational, other than at some point I accidentally knocked an electric connection off the spreader. And so my 40-foot extension ladder won't reach that high. And so
Oh.
somebody has to dangle like 50 feet in the air down from the
Ooh.
top to connect these wires that may or may not been hit when we were trying to unplug it. Remember early in the winter when we had that
Mm.
plugged sump? And so we had these 20-foot sections of rebar and we ended up poking holes in the bottom of the bin. I'll complain about that too. Brand new bin with holes now in it. We were, yeah, that's another fix
Oh.
it, right? Because you build a $250,000 bin and then you have to go in and patch the holes. You put it in on year one because of this plugged sump. There's so much to unpack in that story, Renee. We'll get to it on the
Oh,
next episode, though.
I
I
can't
promise.
wait. Well, and in some cases, this could cause workplace violence, right? If
Yes,
you figured out that your friend is who poked the holes in the bottom. Next thing you know, you too could have violence in the workplace.
right.
Maybe sometimes I won't even say it. I was good. No, I won't say it. I was gonna say maybe some of those farm place accidents aren't really accidents.
Well,
Um,
yeah, it's
you
not
know.
good.
So today we are going to talk about workplace violence, and it is a real concern. And so let's kind of talk about what it is. What is workplace violence? And I know I shared just recently. I've been involved in this, but kind of from your perspective, Jason, as we're out talking to people, what are you hearing as some of the stories that of what's going on in the workplace, especially if we're thinking of hospitals and our provider groups? What's going on out there?
Well, I mean, I'd like to preface with this is nothing new. I mean, we call
No.
it workplace
No.
violence, but I mean, I've worked in residential treatment facilities my entire career. I
Yeah.
started out working in locked, gated facilities with adolescents, and violence was part of it, right? Whenever you contain
Right.
people in a setting, people tend to get violent, especially if they have a mental health condition or a
Right.
substance use condition. And so when we look at institutions, residential treatment facilities, we've had to manage violent people, whether it's children or adults, forever. I
Right.
think we're seeing an increase of this thing, especially in hospitals. And so
Mhm.
hospitals are struggling to make the change of who is this new population that historically they may not have served. And so, I think that's where now, we've retermed it workplace violence. Well, I think there's other things that we could better talk about this, right? It's about how are we managing everyone's emotions in whatever setting someone presents at. And, I can tell you, and we'll get to it later, because my opinions and my soapbox come out on this. People are only violent when we escalate them. If we have good de-escalation practices and policies and procedures and trainings in place, people don't escalate. And that means people don't become violent. If someone becomes violent, we missed all the signs that caused an escalation to the point where someone became violent. Even if someone's internally preoccupied, actively psychotic, you can still de-escalate the person, because I've done it numerous times across my career, in locked settings, in open settings, in all of the settings we're talking about here today. So I don't have a lot of tolerance when people tell me that people are just violent and there's nothing we can do. I don't buy that for a minute, Renee.
Yeah. Well, and I've been involved too. So, I mean, I started in psychiatric hospitals. I was a mental health technician as I was finishing my master's degree and as I was working on units, all different ages, and saw all kinds of things. But you're right. I've had to de-escalate on a L train pass in Chicago. One time I walked too far away from my people I was traveling with, and I forget about those kind of tucked in positions where people can stay heated. And I walked past it to read a sign, and he popped out behind me. And my friends and family kind of freaked out that he was behind me. But, if you've got those skills and you can use that voice of just like, that you weren't really trying to hurt anybody or do anything, you can really talk people down. And, sometimes I got lucky. I mean, I won't say it was all just skill, but there's other times I'm like, you're right, there's some challenges. And shoot, I've been hit and kicked and bit with the best of them through my years in adolescence. So I did it wrong and then learned to do it better. And so I'm excited today about this conversation because there's a lot we can learn on how to do this and how to do it better. But one thing I wanted to talk about before we get into the data, this is really underreported. And what's really not good is when administration don't take this for what it is. And we've heard, when you're hearing staff assaults and things, just the ratio of what actually gets reported is very low. And then sometimes, I don't know about you, Jason, but I've been in a situation where bad things did happen, and then they didn't really want to report it because they didn't want to deal with workman's comp, or they wanted to try to say that you had a pattern in this so that they wouldn't have had to deal with it with workman's comp. And so there are some tricky parts to this, because if you do get injured on the job, you are supposed to have availability to you to get help. And it is the place's fault and their job to help you get that kind of access to care. And that's part of the whole workman's comp system. And we all have to pay into this system. But there are sometimes some really bad stories out there of people who did get injured and then they don't want to use those services. And so we won't talk too much about that today, but I just want to know that we know and we are aware that the data we're going to talk about is probably not as accurate as it could be because of some of these factors, either due to underreporting or not wanting to report or changing. And I remember one particular issue I was involved in, nothing more fun than getting called in with the CEO on a Sunday morning because something went wrong on Saturday night, let me tell you. So I've been there, done that. So let's talk about the data, Jason. What are we seeing out there as what is reported?
Well, and I think that you make a good point as we move into data, thinking about, we remember when the ED got destroyed or the $50,000 bill to have to redo a room in the emergency department, but we don't remember the 500 other times that everything went well. And so sometimes that clouds the data because it's not reported. I was at a hospital earlier this year, Renee. We were doing work at a hospital, and the HR people said, we know we don't get all the incident reports on these. We know the nurses aren't completing the incident reports. I'm like, then how do you know what your problem is? How do you know this is a real issue? Because you don't have accurate data. And everyone in the room, including the CEO, said, yeah, we know we don't know what the real problem is. In people's mind, it's a huge issue. But in reality, we can't actually put a number to it, And so I think that's the challenging part, to have an open and honest conversation about this, because it's a serious issue. Like if staff are being assaulted repeatedly, then there is a problem. But how do we figure out the problem if we're not measuring it? And so we know across the healthcare industry, healthcare workers, nurses, and EDs are 5 times more likely to experience workplace violence than other industries, right? So we know this is a huge problem. We know workforce violence accounted for, the rate of 14 non-fatal injuries involving days away per 10,000 full-time equivalent hours, right? So we know people are having to take time off because they're being assaulted. A lot of times it's not serious assaults, but I've been bitten. It's not comfortable, right? It's
Mhm.
uncomfortable. Sometimes you have to go through a series of shots. It's something that it's psychologically draining, right? And I think that's the part of this where we see the increases. 85% of healthcare workers report increased anxiety, 60%
Mm.
depression, 81% burnout. That's data from the CDC. And really, that's because of that ongoing being in that environment where you may be assaulted or you have been assaulted, and that's traumatic. And so we need to recognize the trauma that's embedded in all of this. And so the data doesn't look good for healthcare workers, right? Because these are a lot of negative impacts that come from these assaults.
Right. And if I mean, you have been around as long as I have, and you probably were trained the same way I was originally. The thought process behind a lot of this the workplace kind of incidents was restraint. And we were
Right.
taught how to quote safely restrain. And I'm telling you what, I got injured more trying to restrain than I ever would have if I would have just
Yep.
de-escalated and kept hands off, right?
Yep.
And so even in corrections, some of those things have changed. So like if a person comes in parole and they're going to be arrested or whatever, they don't put hands on anymore. If the person chooses to walk away, get a warrant, and then deal with the arrest down the road. And so there are changes that even we have made through the years that maybe restraint wasn't a great call because I was trained in restraint and I wasn't bad at it. But boy, between your own body and what your body, the stress it went through, and then maybe some of the injuries that would happen through restraint, it just wasn't very fun. Now, there are times where some people have to be restrained. And I think in
Right.
my prison system, we do have some that are really violent and, have already been hurt people in lots of other settings. And so we try to de-escalate and maybe do the best job when maybe not. And so there are some challenges and some very rare restraints, but it isn't the culture anymore. I know in the 90s, 2000s, that was a lot of what a lot of the training was. And so today we're going to talk differently about training and that it's not that. And I'm really grateful for that. I mean, I still have those skills way back in the back of my mind, but I don't use them anymore unless for
Mhm.
some goodness terrible reason I'd have to. So what are you thinking about training? I mean, it really has shifted, hasn't it?
It absolutely has, but those trainings are still out there, Renee. There are still
Oh, yeah.
trainings that are more focused on what to do, how to, manhandle someone, and maybe not put as much emphasis on the de-escalation side of that. Unless someone's an imminent danger to themselves or someone else, I really don't understand why we're forcing them into a room and locking the door. And so a lot of our accreditation bodies, we look at JCO for hospitals, they've really clamped down on that and said, no, you can't do that. We've seen the same thing happen in residential treatment facilities. But let's be honest, emergency departments are kind of late to the game because they're not managing people over a long period of time. They're managing people during that time period where they're experiencing an acute condition, or someone's showing up to the emergency room in a crisis and they're escalated. And so it does take extra training and extra guidance. And all trainings aren't the same. I think that's kind of the takeaway. I was at a hospital here, 3 or 4 months ago. I sat with them and I said, well, how are you managing your ED? What are you doing? And they're like, we did a study and we found that we switched companies of what training we used. And we saw a
Mm.
spike in workplace violence, in assaults on staff.
Oh,
And
boy.
they had an intern that ran data analysis, and they were able to show a correlation with when they started a new training
Wow.
company.
That's impressive. We talk about that a lot, how we make those kind of changes and then we don't look at the data and see
Right,
how it's actually changed. So kudos
right.
to them to be able to pinpoint a shift because a lot of people, we just make those tweaks and changes. And we've gone on about that in
Right.
previous episodes about how we never look at if it's made any difference at all. So kudos for checking that out. But
And
wow, the fact that that made such a huge difference with just
and guess
changing
what?
training.
And they went back to the old training module that had been
Yeah.
updated, and they saw a decrease in
Right.
workplace violence, a
Right.
decrease in assaults. It was
That's
all
awesome.
about culture and education and training. And so this is really a culture issue more
Yeah.
than anything. And so when you think
Agreed.
about, it's the culture of your emergency department, it's the culture of your unit, it's the culture of the program that you work in. And I think where is the emphasis on that? So oftentimes when we talk with hospitals, the CEO is worried about, well, where are we going to come up with another $50,000 to fix all of the issues, of broken equipment? and all this stuff. And they're not saying, well, where are we going to invest in training so that we can prevent this? It doesn't mean it's not going to happen at certain points. It may happen.
Or, or like you and I've seen in some of these hospitals, maybe we shouldn't have put folks with behavioral health issues in those rooms with the swinging,
Right,
dangling lights from the
right,
ceiling. And maybe
right,
we should have created the space correctly in the first place. We would have
right,
had less damage, right? Because we've
right.
seen some crazy old hospital designs, and you're like, yeah, they're beautiful, but wow, that's not going to go. And then, of course, it doesn't. And the first person that comes through destroys all the things that you and I can see that that's a
Yep.
terrible choice. And so, yes, it is expensive, but it doesn't have to be. I mean, on that end, it's a design preference and it's a design. There are people out there whose job it is to design safe spaces. Those are
Right.
the spaces we should be using in these kind of crisis situations, not the ones that have all the glass and
And
all of the
and a trauma
chandeliers.
and a trauma informed safe space isn't just a blank walled room, right? We can still have some
No.
color. We can still create a space that has comfort, and a couch that's safe, that meets certain criteria. You can still create a safe place that doesn't have to be miserable, because remember, we talked about in previous podcasts, someone's going to sit in that room for 4 times longer than someone who's there for a medical condition. And so we're talking someone could sit in that room for days. And if you go to some of these, I quote, safe rooms, I go into them for 10 minutes and I'm like, get me out of this room. This is horrible. Um,
Right.
we do need to think about how do we design spaces that are actually usable and
Right.
functional that people want to be in.
Well, I think of the new hospital wing up there at Mary Greeley near you, and they've got that furniture that's
Right,
created specifically for this purpose. And so they've got furniture that's made to not be destructible, but to be comfortable, to not be harmed. And so, there is thought that can go into this. And so it's on the front end of these conversations. It's not after the fact that something's destroyed, and so and there's two parts of this. We're talking about workplace violence, two pieces. One is the planning of your space, and but then the second part is the training and like making sure that your employees who come in contact with people have the appropriate training. And we've talked about this story before, but if you recall, in one of the hospitals we were at, when somebody was escalating, they were going to do this all call for all employees who happen to be available to
right.
show up. That did not mean any of them had been trained in de-escalation.
No.
And then you're going to have them from who knows what departments showing up in what kind of outfits, and they're all just going to escalate that further. What a terrible idea. And so you can think through like some of that preventative things about like whoever you decide are going to show up, they should be the ones trained in de-escalation and making sure that that is who shows up, not just anybody, because
The
then those extra people just get harmed.
Right. I don't think always the third shift maintenance guy is the right person with the right presence. He may be, maybe not.
But if he
Um,
shows up with a mop and a bucket, it's going to turn into a weapon and someone's
right,
going to get clocked.
right.
It's just like, let's think that through. I mean, it's like we've got the broom, we've got the mop. I mean, what are we trying to do here? And so, it's just like thinking about like there's just so much here that can be prevented. A lot of this is about preventing violence, and you have to set the stage for it to go well and think about it from a calm perspective with the colors, with the atmosphere that's calming, the music that's played. All of the things can add to the ambiance that helps it be calm and to de-escalate. And you can set it that way, or you can go the opposite way and just gin people up from the beginning and then wonder why somebody got violent. And that's just backwards. And so
And
there really is a lot more forethought to go into this.
And then, of course, having policies and procedures that clearly
Right.
outline how you respond, who responds, who gets trained, right? We've talked before, 60% of rural hospitals don't have any criteria or policy around how to assist a young person, an adolescent who presents in the emergency room for a behavioral health condition. There's no policy, there's no procedure, there's nothing in writing on what they should do, how they should respond, how they should manage. And so the number one thing to have forethought is not just in facilities, but also in policies and procedure, clinical pathways, partnerships, all the things you need to have connected back to the community in writing. So whoever the nurse is on staff that night knows where to go, who to contact, and what the protocol is to manage that person.
Yep. And if you're listening and you're like, well, I'm not in a hospital, this still applies to you. The folks that struggle that show up at the hospital show up lots of other places. They'll show up at the pharmacy, they'll be at Walmart, they'll be at the convenience store, they're in your office location, and you still need to know how to handle people to de escalate. I think about just in my own office, we've had a death of a coworker, and how it's handled matters. People,
Mhm.
dealing with their feelings about losing someone, it matters. And to think of, there's right ways and there's wrong ways. And I've seen both of,
Mhm.
like, the impersonal, oh, by the way, email, or taking the time to walk in and tell somebody who's going to be, upset, and give them as much information as you can and listen and let them process. I mean, there's different ways, and they may not become violent, but they definitely get that anxiety and that stress and that depression that we've talked about that leads to burnout. And if we don't handle just day-to-day issues with some tact and some that de-escalation, that's a skill that you can use anywhere. And I've used it at playgrounds. I've had to use it at church. And so things happen. And so bad things happen and people get upset, and there's ways to help them process through that if you're trained. So training is such a huge part. So Jason,
And
talk about what specific types of training might we be talking about here that could help? Do you have ideas?
well, I have, yeah, I was just going to say, there's all kinds of trainings you can do. And it just starts every training that we do. I think about Notice, Talk, Act, Question, Persuade, Refer. I could go through acronym soup of all the trainings, mental health, first aid. A lot of those trainings aren't necessarily healthcare centric, but they're office, they're community based, they're community centric. And then there are
Right.
trainings that are specific for healthcare staff, for
Mhm.
suicide prevention of folks who work on the unit in acute care. There's a level, a progression of trainings all the way through. They all start with getting comfortable having a conversation with someone, right? At
That's
the
right.
end of the day, every one of those trainings is, in order to de-escalate someone, you have to talk to them. You can't just run away. Every one of those trainings I teach, whether it's in schools, whether it's in a healthcare organization, whether it's a community training at a library, starts with, we have to be comfortable having uncomfortable conversations with individuals who may be experiencing suicidal thoughts or may be experiencing auditory hallucinations. We simply need to be comfortable having a conversation and not freaking out ourselves, because that's what escalates people. You
Right.
escalate people because you escalate, and people follow you up that escalation path. I mean, I'm suddenly doing a training, I feel like, Renee. But, as I think about all of those different flavors of training that we do, specifically, it comes down to matching the training with the staff, right? It may be the janitor in that hospital doesn't need the same training as the RNs, but everyone needs a training that's evidence-based, that's going to help them to manage, because they're all going to come into contact with those same patients over the course of a 24-hour period. Everyone should have training. And so oftentimes we go in and talk with a hospital or facility, and they're like, well, we don't train that group of staff because they won't have contact with clients or they won't have contact with patients. No, I think they do. They actually may have more contact with patients than you ever believe that they do. And they probably need the training because they may have a bigger impact, because they may have a more calming presence just being in the hallway, and someone may see them as protective. And so sometimes I'm big on the housekeeping staff. They sometimes have way more weight to carry than anyone gives them credit for.
Yeah. Well, I also think just about all the specialists and the particular types of doctors. We
Yeah.
all know better than to think that all of them are really good at de-escalation or even having bedside manners. We've all met docs that are not good at this. And we've heard stories in Southern Iowa. I got a call once that the guy was like basically banned from the entire hospital network because some doctor took whatever he said as a threat, and so therefore banned him from his hospital. But then it's a hospital system, so he got banned, so he couldn't even get health care, and
Mhm.
ombudsmen and people in the state had to get involved, right? Because sometimes doctors don't know what to do.
Yep.
And so that concept of the provider training is so helpful. We talk about it often because it's really important. We talk about how we're training like podiatrists, you're training osteopaths, you're training, rehab specialists, whatever, because you still come in contact with folks that are in pain and that have mental health concerns. And so if you're a person and they are in a chronic pain situation or learn they have cancer, you could easily escalate into something that it's not maybe your training or your gifting or even your particular training path, right? But that doesn't mean you shouldn't know how to de-escalate people. Healthcare should be a people person system. So nurses in any area of the hospital need to know, and that the doctors in those areas need to know, if and not just not treat people because they have a condition they don't understand. And so, it's a hospital wide. So don't just assume, don't even assume your psychiatrists know how to do this. I've met some psychologists and psychiatrists that I don't think have this either, and they would not be good in a crisis. So just make sure that everybody's included, right? Don't single anybody out. Let's include everybody. And provider, we always talk about provider because it's an awesome training to give people firsthand knowledge of what it's like as a person or a family member with those issues, with mental health concerns, on how they want to be treated and some of the barriers that they've run into and some of the escalating statements that have been made to them through their treatment history. It's really, really fascinating to listen to people of what doctors have said to them. And then they wonder why there's workplace violence. It's like, you just said something horrendous to this patient, and then you're wondering why they, might have got mad at you.
Right.
Crazy, crazy. Anything else you wanted to share about this before we talk about our self-care policy of the week?
No, I think we're ready for the self-care policy of the week. 'Cause I think this conversation really lends itself well to, these are stressful positions, and our healthcare
They are.
workers put themselves at risk every day to manage situations that they have no idea who's going to walk in the door next. And that can be a very stressful job
Yes.
because there's some days there's nothing going on and it goes great. And there's some days where you want it to be that day and it's not going to be. And it really goes off the rails very quickly. And so that's a really hard job to have. And so, I certainly extend my gratefulness and gratitude to all of those folks who do those jobs that take care of people all the time, because it's really hard. It's hard
It is
work, and
very
they
hard.
really have to take extra steps, as we talked about in the data, to take care of themselves, because those
That's
are
right.
high burnout, high stress, at risk jobs.
That's right. Yep. And so that self-care policy of the week for the recovering politician is about asking for help. And we all sometimes think, well, that just means we're talking professionals and that you have to have money to do that. No, you don't. I mean, there's so many people out there that'll be willing to help if we just ask them. And what are you talking about? Maybe it's just somebody that you can tell stories about the crazy stuff that happened at the office this week, and they don't have to work in your office. And most of the time it's better if they don't, because then they don't know the players and you can just kind of vent about whatever you needed to talk about. Or if you're the only one of something and you're like, there's nobody else has a job like mine, you don't have to. You could find maybe another business owner, if you're a business owner, or a colleague or a friend that is just open to listening and letting some of that stuff out. One, it shouldn't all come home because your spouse shouldn't have to take all of it. And second, other people want to share their stories and their lives too. So it becomes a two-way thing. You can learn all about whatever they do that's very different than what you do and be a resource for them. And so just making sure you ask, because there's a lot of people out there I could help, but if they don't want the help or they're not asking, I don't just go volunteer, say, hey, let me help you. I just kind of sit back and wait. If somebody asks for help, those are the folks that I'm the most likely to help. And that's generally how most of us are. So just don't forget that all of us need help. We work in healthcare. It's a very stressful business, and all of us need to be thinking about how to take care of ourselves so we can help take care of others. So today we started out talking about Jason's bad day on the farm, but then we continued into workplace violence. And there's tons of things we can do for prevention through training. And so if you're not sure what to do there, please reach out to us. We've got so many ideas for you, and we could talk specifically. Jason's really good at being able to kind of assess your situation at your place of work and say, this might be a good training for you, like how much time you have to put into it, maybe how much cost you have, the budget you have, and be able to say, this would be a great resource. It's a place to start. The best thing you can do to prevent violence is to train your people. Before we go, we just want to ask you to please follow us on LinkedIn, Facebook, or YouTube. And if you decide to leave us a positive review about this podcast, we'll send you a prize. Thanks, everybody. Have a great week. We'll see you next time.